So next up is going to be Sam Goldman. He's currently an assistant professor of emergency medicine at the Alpert Medical School of Brown University in Providence, Rhode Island. In addition to being the co-director of the stroke centers at Rhode Island and Merriam Hospitals, he has particular interest in medical education, resident and medical student mentorship. He completed his emergency medicine residency at Brown Rhode Island Hospital and is a graduate of UMass Medical School. Prior to medical school, he completed an MPH at Boston University School of Public Health with a focus in epidemiology. He completed his undergraduate degree at Brown University, where he's a member of the Brown Men's Crew. Outside of medicine, he's an active participant in the Brown Emergency Medicine Run Club and is an avid sauna enthusiast. Sam,
Hey,
you
guys.
able to jump on?
Awesome. Thanks for having me. Let's see if I can share my screen. Can you guys just see my presentation or can you see my speaker notes as well?
I don't see your speaker notes. And just for anyone, I think that you now have tabs available. You can switch back to the main conference slide. There's nothing to see there. So stay on Sam's.
All right. So thanks a lot for having me. I'm Sam Goldman, not formally sports medicine trained, but enthusiastic about it. And thanks to Jeff Fedden for plugging me in with you guys. So I ran my first ultra marathon this past August 2024, and I had a pretty wild experience. And I'd love to talk to you guys about some lessons learned from that experience. So first, we'll talk about what is an ultra. It technically refers to any extreme endurance distance across a number of disciplines and a lot of different formats. But most commonly, they're in the form of running, cycling, and swimming. With respect to running, in particular, an ultra is really defined as any event over the distance of a marathon or 26.2 miles. So we can dive quickly back into the history of this kind of weird endeavor. Particular to running, the ultra distance, really, this goes back to 1870s, where competitive walking emerged as a sport called the pedestrianism craze. In the late 1800s, it involved races, usually in a last person standing format, or the most miles traveled in a period of time format, often around a track. Here's one such pedestrian, one of the most famous athletes in his day, named Frank Hart, who in 1880 walked a record-breaking 565 miles in a six-day match. The sport soon went into decline, and historians think that it was probably due to the rise in popularity of the bicycle. Distance events from the late 1800s onwards were usually confined to a marathon distance, which came into fruition in the 1890s to celebrate the run in Greece. Modern ultramarathons really emerged and exist across a number of distances, surfaces, and formats. And here's a few that I'd like to highlight. The first being the oldest in North America is the JFK 50K race. It started in 1963, and it was a push by JFK to bring the country back to physical fitness. Another one that you may have heard of if you peruse Amazon frequently, this pretty good documentary on the Barkley Marathons. This is an annual trail race that consists of 5 laps of a 20-mile loop. And runners have 60 hours to complete those laps. And this race is so technically grueling that despite the pretty lenient cutoff, since its inception in 1986, only 20 individuals have ever finished the race. Another format that's important to cover and sort of be aware of as sports medicine practitioners is called the backyard, as it's gaining popularity. A backyard is another last person standing format where competitors must run a distance of 4.1 miles in less than an hour. This pace really amounts to 100 miles per 24-hour period. And this race is only over when one runner remains to complete a lap. So it's an indefinite race with only one winner. The runners mark the winner only after all other winners have DNF'd or did not finish. And for reference, just to see kind of where we stand with this sport, the world record was set this past April at the World Championships, and it's 110 laps consecutively every hour on the hour, and that equates to 458 miles. So imagine just running over 4 miles every hour on the hour for 4.5 days straight, and think about the kind of special considerations and toll that takes on the body. So we've talked about what an ultra is, but I think really the big question is why is this a topic at all? Um, do people really do these things? Isn't this just kind of a fringe extreme event? Um, and it turns out that while a minority of athletes partake in an ultra in any given year, it's really a rapidly growing sport. So I think it is important to be aware of. Here's really a heat map of all the ultra running events, 50K or longer in the US in the year 2000. The larger circles reflect the size of the event in terms of participation. And here's that same heat map in 2023. So if we restrict that to the 50K distance, the number of races in the US since the year 2000 has really gone up by about 750%. And so if we look at and restrict that to the 100-mile distance, obviously there are fewer. This is the year 2000. There's just under 20 of them. And here's 2023, almost 150 of those races exist. So you're thinking maybe more races. This doesn't necessarily mean the sport is booming, just more people are doing more races. Aren't there just kind of enclaves of these freak, athletes all over the US? And yes, there are. But to illustrate sort of the draw and the pull of these races, here's a depiction for a pretty popular old race at the 100-mile distance called the Javelina 100, located in Arizona. And we can see as time progresses, the average distance of travel for participants really increases. So ultra running is really a big booming thing. Demographically speaking, ultramarathons tend to favor men to women. Perhaps surprisingly, there are a number of older competitors across the field of ultras as well. And people seem to be figuring this kind of sport out. So not only do we see more participants, we see higher finishing rates. So what's behind the phenomenon, the growth of the sport? I think it's probably multifactorial. Some things that I've read and interacted with have suggested that the rise of social media influencer culture, these pretty popular, charismatic folks play a role in bringing a fringe sport to the masses, for better and for worse. It was seen that after the release of the Hunger Games books, there was a surge in participation in archery. So, it does exist that these popular social influences have an impact on the participation in sports. So we've talked about what ultramarathons are and potentially the factors that lead to their increase in popularity. But let's focus on one in particular, my particular participation, and really use it as a lens to discuss some special considerations in sports medicine relating to these kind of wacky races. So I'll talk about the Leadville 100. It's located in Leadville, Colorado, and Leadville has this special designation as the highest elevated incorporated city or town in all of North America. It sits at an elevation of 10,152 feet above sea level. The Leadville 100, also called the Race Across the Sky, is held annually in August. It was started in 1983, so it's in I think it's the fourth oldest ultra race in the United States. And it was started by Ken Kluber, a local miner who wanted to bring tourist and economic vitality to the town of Leadville after the closure of its main industry, which is its silver and copper mines. So just to briefly touch on the course, and then we'll talk about a little bit my experience there. But it's a 50-mile out and back course with roughly 18,000 feet of climbing over its distance. And what makes Leadville really one of the most challenging 100-mile races in the world is that not only does the course never drop below roughly 9,500 feet above sea level, it takes you up to 12,500 feet at the crux of the course called Hope Pass. You can see that kind of Batman spike in the center. And because it's an out and back course, it means that you not only go over that peak once, but twice going out and back. As with most 100-mile ultras, there are time cutoffs at aid stations along the way, and the overall cutoff for the course is 30 hours here. So just to touch on a little bit of the training considerations in ultra, there are a lot of schools of thought for how people should or ought to train for ultra. And that really varies between those approaches vary between elite level athletes and then people like myself. But generally speaking, the considerations for training in an ultra and what you might see in your patients or people you work with, it involves a lot of low intensity volume, which biomechanical optimization, such as stretching and muscular training. Um, Personally, to avoid overuse, I stuck with this 10% rule where my weekly mileage wouldn't increase by more than 10% from week to week. And I capped personally around 70 miles a week, but you may encounter individuals who go upwards of 100, 120 miles a week. Um, Preparing one's feet is pretty important. I have some gruesome pictures I'll spare you from, but there are pretty unique stresses faced during races of upwards of 24, 30 hours. For me, this involved a lot of experimentation with blister prevention, trying out a lot of different products, tape, and different shoes, sock combinations. And something we'll touch on a little bit more is nutrition. My running coach would say ultramarathons are eating competitions done while running. And we'll circle back to a little bit of that. Another consideration is training for the sleep disruption. Um, for all but the elite or athletes or the people who win these races, the nature of ultra endurance sports means that they'll traverse the normal sleep wake cycles that we all experience. And so people have to really focus on training how to be active, how to have their gut activated, their mind activated at times that they're used to being asleep. And then lastly, preparing for the particular environment of the race. We'll get into that a little bit, but living at sea level, I felt it was important to try to acclimate to altitude. So I rented a hypoxic tent and slept in it for about a month leading up to the race. And then I arrived in Leadville about 1 week before the race to acclimate as well. So we'll get into the race a little bit. I go to the start line around 4 a.m. With about 600 or so other runners. And the first segment of the race pictured here is kind of a blur of excitement. Everybody's really excited. They're tapered from their training, hopefully healthy, ready to run. The first part of the course is mostly downhill, descending out of town towards Turquoise Lake. And the first aid station comes at this 13 and a half mile mark. And it's a pretty surreal experience, sort of leaving the starting corral with 600 other people in this mountain town in the night, kind of illuminated by 600 other headlamps. So I focused on running my own race, getting ahead on nutrition, and I ate as much as I could, as often as I could. So we can talk specifically about nutrition. I see there's some chat there. If somebody can interrupt if that's important to talk about. But physicians and providers encountering athletes with ultra endurance events, or even sports in general, I'd argue that advances in nutrition and fueling are the single biggest factor that's led to some of the athletic performance improvements we've seen in endurance sports in the past 5 years, thinking about the cycling peloton and the Tour de France and certainly ultra sports as well. With regards to ultra nutrition, depending on environmental factors, an individual athlete can really have fluid losses exceeding 2 liters per hour. So not only does volume loss impact performance by contributing to an energy deficit, care has to be taken during repletion to account for electrolyte and solute loss to avoid exercise-associated hyponatremia. And aside from some of the musculoskeletal injuries that people experience, exercise-associated hyponatremia is really the most common occurring medical condition to occur during these events. Roughly 2 to 7% of participants will find this, and usually it's from excessive intake of hypotonic fluid. Ultra endurance participants expend a ton of energy, so upwards of 10,000 calories per day. And these races often last beyond a day. So remember, the cutoff for Leadville was 30 hours. So we're talking about 25,000 calories or so. From a performance perspective, it's been demonstrated that there's this negative relationship between caloric intake and finish time. So the more intake of calories from nutrition, the faster a race time. And more amateur athletes, it's been shown that the more calories taken in, the higher likelihood of finishing a race overall. And this relationship exists across disciplines from running, biking to swimming. And really, athletes in the past 5 years have explored ways to push the boundaries of our carbohydrate consumption. And carbs are the main fuel source for athletes during these events. But it's important to remember that some degree of fat, protein, electrolytes, and minerals are important here too. So elite athletes can take in about 120 grams of carbs per hour, which is about 400 or 500 calories per hour for the duration of these events. Here's a picture of David Roche on the right. He's the winner of last year's Leadville, and it was his first ever attempt at the 100-mile distance. He broke a course record this past year that stood for almost 20 years and was considered to be somewhat unbreakable for a number of reasons. And he entirely attributes his success to his food intake, his gut training that allowed him to take in a astronomical amount of calories and carbs. And they took a really science-based approach to his training, and his gut training in particular. Um, there is evidence that supports that gut training to alleviate symptoms of GI distress during racing. And Roche really kind of tackled this problem with a couple of things, including a process he called slurping. Talk a little bit more about fuel, but this has become sort of a booming industry to accommodate this growing sport. There's a lot of products, foods, gels, powders, mixes, and there's a lot of data to support them with consideration given to food palatability, people's ability to tolerate it in their GI system, and increased preference, which studies show people have as duration of race goes on. Athletes have an increased preference for savory foods as they go longer into races. There's also studies that demonstrate a phenomenon called palate fatigue, which is the loss of the desire to eat a particular food or drink. And palate fatigue seems to be proportional to the distance traveled in these events. A few strategies exist to combat that fatigue, including varying nutrition options, transitioning toward liquid as the event goes, and this thing that David Roche pioneered called slurping, which involves squirting gels into the posterior part of the mouth to bypass the palate. Um, and David Roche really attributed that to being able to take in more calories than other racers. Um, there are some studies that show that a degree of spice intake orally during exercise has been shown to decrease the rating of perceived exertion, or RPE. So there's some products that have some spice or capsaicin involved. And then lastly, strategic use of caffeine and potentially nicotine to sustain performance has been explored in the later stages of ultra racing. So back to my race, I made it to the first aid station, which was called May Queen at mile 12.6. Ahead of cutoff times, I ate and drank as much as I could, and I head out for the next aid station. Here are a couple pictures I snapped on my climb out of May Queen. Here's the next aid station called Outward Bound, almost a marathon distance into the race. And this is the first part of the course where I could meet my crew, which was basically my kids just kind of throwing stuff at me and some friends and family. The concept of crew is a really important topic in ultra endurance sports. The crew is really critical to the success of the athletes, and they're there to help motivate, refuel, but also from our perspective, they can serve as sort of a mini medical service for athletes. There are obviously medical tents at these races for athlete safety, but crews often administer kind of athlete-specific attention during races. The next step of my race would take me toward Hope Pass, that crux of the race. That mountain with unpredictable weather and an elevation up to 12,600 feet. So on my journey to Hope Pass, I started to have a little bit of pain in my left knee coming from my IT band, which kind of slowed my running economy, but I kept moving. This is me almost up Hope Pass. I turned around and snapped this shot about a quarter mile from the summit. And if you look way off in the distance, about 40 miles off is sort of the start of the race at Leadville in the town. Here's a video shooting up towards the summit. You can make out a couple llamas, which the race used to haul some water and nutrition up there with a couple hardy volunteers. I'm about 10 hours into the race here, feeling good, ahead of cutoff times, happy enough to smile for a picture I had somebody take, but that didn't last much longer. So we'll jump forward in my race experience to when things got a little interesting, and we can kind of transition to focusing quickly on some medical aspects of ultra endurance sports. I made it up and over Hope Pass. Cutoff times were getting a little bit tighter. I made it to halfway. I ate some food and turned around to make it up and over Hope Pass one more time. This is the aid station called Twin Lakes. You can see here I am on the left eating a sandwich before going up and over Hope Pass, and then this chaotic blur of a picture is getting back to Twin Lakes at mile 63, about an hour and a half ahead of the cutoff, but not feeling great at that point. And it's here I sort of experienced some medical events. Leaving Twin Lakes, there's a slight climb coming out of that aid station. And every 2 or 3 steps I took, I couldn't really breathe at a running pace or even a fast walk. I wasn't wheezing. I had no cough. Just it was like some external power was forcing me to breathe through a straw. But I had a pacer here who'd run Leadville before. He told me this was normal. It could pass. So I sort of dialed back the intensity and carried on. And anytime I pushed the intensity here, I sort of felt those symptoms, but I could manage my effort level and make it on a little bit to the next aid station, which was outward bound, inbound at mile 78. Here's sort of the last picture of me in the race. At mile 78, this is 21 hours into the race. My fueling had been successful. I had 9 miles to go, 9 hours left before the cutoff to cover the last 22 miles of the race. But as I left the aid station, I really experienced those same respiratory symptoms. And this time I couldn't dial back the pace, and nothing I could do would help with my symptoms. So I was tachypnic. I had sort of this cough, and any sort of exertion made me feel pretty pre-syncopal. Um, I had enough time where I could walk it in, and I knew that I was going to tough this out. But as I started climbing the last climb of the course, where that red arrow's pointing, about a quarter mile from the top, about 80 miles into the race, I got to the point where rest did not relieve my respiratory symptoms. So it wasn't pain. It wasn't something that I could kind of tough myself through. It was just something was really wrong, and I had to recognize that. And my pacer at that point, thankfully, had cell phone service and called the medical tent, and some ATVs came and rescued me out and brought me to a hospital in Leadville. So we'll talk a little bit about what happened, but altitude illness is really the crux of it. It's a collection of clinical conditions, somewhat on a spectrum, though with distinct features and pathophysiology. Really, up to half of people who ascend to heights of greater than 2,500 meters will experience symptoms of acute mountain sickness. And just for perspective, the Leadville 100 course is elevated above 2,500 meters for its entirety and goes up to 4,000 meters at Hope Pass. The incidence of acute mountain sickness is proportional to the elevation attained and the rate of ascent. There's no gender difference in the risk of developing it. One study of climbers in the Himalayas found no evidence of previous episodes of altitude sickness, the weight carried, any recent illness being associated with the development of it. There are some medications to prevent acute mountain sickness. The most robustly examined include acetazolamide and dexamethasone. Both medications reduce the risk of developing acute mountain sickness compared with placebo, but their efficacy compared to one another is generally not agreed upon. Regarding side effect profiles, acetazolamide causes polyuria and paresthesias in a high number of people. The polyuria, in the case of endurance athletes, has to be taken into consideration, especially given the nutritional needs and the fluid losses we talked about earlier. Acetazolamide may be helpful in preventing the onset of symptoms, but it's less effective at treating symptoms once they've been developed. Dexamethasone can cause some psychiatric conditions in individuals after the withdrawal of treatment, but in contrast to acetazolamide, it does appear to have some benefit in reducing symptom severity in people who've developed symptoms. Further along the spectrum of altitude-related illnesses is high altitude pulmonary edema, or HAPE. HAPE's clinically characterized by severe dyspnea, cough, difficulty with physical exertion, and cyanosis. It typically occurs within 1 to 2 days of ascent, and the risk of development seems to increase with the additional risk or stress of exercise. The pathophysiology of HAPE involves an exaggerated elevation of PA pressure, pulmonary artery pressure, in response to the ambient hypoxia of altitude, which is made worse with exertion and is thought to be a result of impaired mechanism of nitric oxide production. Here's really a schematic of the pathophysiology of HAPE with respects to the pulmonary circulation in the alveolar space. So HAPE really arises from the interplay between an elevated PA pressure leading to hydrostatic pulmonary edema with altered alveolar capillary permeability. And modest ascent slows that rate and rise in PA pressure and allows for that adaptive remodeling of the microvascular structures. And there are meds here that target both sides of this equation, either aiming to reduce the PA pressure directly or reducing microvascular pressures or addressing alveolar fluid leak and absorption. Generally, as with all forms of altitude-related sickness, prevention involves slow ascent. How slow is slow? Well, the recommendation is for less than 300 meters of elevation per day at elevations above 2,500 meters. And talking a little bit about medications here, so specific to the prevention of HAPE, several meds have been studied, and they include phosphodiesterase inhibitors such as sildenafil and tadalafil. These would increase nitric oxide availability in the pulmonary circulation, reducing that pulmonary vascular tone and fluid leakage into the alveolar space. Corticosteroids increase nitric oxide availability. Beta 2 agonists like salmeterol enhance alveolar water clearance by stimulating sodium channels. It's unclear if acetazolamide helps prevent HAPE to the extent it helps with AMS symptoms in the literature. This is one particular recommended approach to the prevention of HAPE. I'm happy to share these slides if this is helpful to anybody. And the treatment of HAPE, this is basically all I remember from my board studying in medical school, given that I live at sea level, is really descent, 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 which is, in fact, the most effective and definitive therapy for all of the altitude-related illnesses. But through my experience as a patient now, and to some extent as a physician, I understand that telling a patient they're going to go somewhere and the logistical act of sending them somewhere is really not a small thing. People's expectations to continue doing whatever event or endeavor they're doing, and the logistical concerns and constraints about sending them somewhere else are considerable. So in situations where exertion is required for an individual to descend, like mountaineering, medications like nifedipine, sildenafil, and dexamethasone have been studied and shown to be effective at restoring oxygenation and improving symptoms of exertional dyspnea to help a person descend. Here's another kind of schematic for treatment of HAPE rather than the initial schematic, which was geared towards the prevention of HAPE. And obviously, descent is the common theme of all of this. Sildenafil is really attractive in this model in particular because it promotes this pulmonary vascular vasodilation and this reduction of PA pressure without the systemic vasodilation that you could expect with nifedipine. But there is a small study out of the Himalayas which didn't show any clinically significant episodes of hypotension with the treatment of nifedipine in patients with HAPE. The expert recommendation is that in a medical setting where supplemental oxygen and bed rest are available for 24 to 48 hours, vasodilatory treatment is really not necessary, and resolution of symptoms can be expected within about 6 to 8 hours on oxygen. You might ask, what about BiPAP? While it's been shown to increase arterial oxygen saturation by about 10 to 20%, if used at high altitude, it has been associated with an increased risk of high altitude cerebral edema, thought by increasing the cerebral venous pressure. High altitude cerebral edema, or HACE, is really the most severe clinical manifestation of high altitude sickness and is potentially fatal, characterized by that ataxia, fatigue, and altered mental status. Thankfully, it occurs more commonly above elevations of around 16,000 feet. And given that Leadville is really the highest ultra sport in North America, I won't really get more into the pathophysiology or prevention or treatment of HACE, but it really is important to consider when discussing altitude-related medical conditions. So back to my particular race, I was hypoxic to about 80% at rest when I got to the ambulance. My chest X-ray showed pulmonary edema, and I was diagnosed ultimately with HAPE. And a touch of rhabdo for a good measure. I was put on supplemental oxygen for about 8 hours and kept in Leadville without additional medications, which, in retrospect, really does adhere to that schematic. And then I descended to Denver in the morning and stayed for a few days recovering before coming to sweet sea level oxygen. And that was my Leadville 100 journey. It was my first ultra. It will not be my last. I learned a lot about ultra endurance sports in general in my preparing for this race, and obviously altitude. But the specifics regarding nutrition, um, the considerations given to sport specific training, the reliance on a crew of people here is really critical. And I think it was really eye-opening at what can go wrong beyond what I've learned in school or training, or even what I've seen practicing in emergency department. Here are some references. Happy to share those. Happy to entertain questions if there's time. But thanks a lot for having me.
Uh, Great talk, Dr. Goldman. There's a couple of questions for you. One of them was, one, where did you rent your tent from? And a follow-up kind of also related to tents was, did any of the medical tents actually have any of those medications that were used for treatment on hand, like when you sought care?
I rented my tent from a and I should also add I have no financial disclosures here, but I rented a tent from a company called Hypoxico. Um, I'm happy to send anybody that information, or they have a pretty good website. And the medical tents, it's sort of an interesting experience. They have medications. They did not have altitude related medications. If you asked for medications at these races, including Tylenol or ibuprofen, even you would be disqualified from the event. So people generally steered clear, and they did not have access to a lot more. The transport time to the hospital at any point in the course was really never more than an hour. So they didn't really have anything beyond supportive care medications.
And in the Q&A, Samantha asks, in hindsight, is there anything that you would have done differently to prepare for the altitude?
I like that question a lot. It was really the nidus for why I gave this talk, because this is an event that is important to me, obviously, and one that I want to complete. So there was this self-serving aspect of giving this talk, as I researched kind of what I can do differently next time. I'll probably pre-medicate. So I will probably, based on my reading, take some medications, have some for if I develop symptoms, and probably prolong my exposure to hypoxia. I'd probably go to Leadville a little bit earlier than 1 week next time.
Quick question just from me, Sam. What recommendations would you give for a physician who's taking care of an ultramarathon athlete?
It depends on the context. I mean, are we talking like an ultra marathoner who's sick with a complaint, or just kind of helping
I
them prepare?
think I think you have a patient you see in your clinic regularly who says, "I'm training for an ultramarathon. It's going to be in a couple of months. What should I do so that I can finish it?"
Yeah, I think this is where a huge amount of learning came from me. When I first started, I didn't have a running coach. I never had run an ultra marathon before. And I thought, well, I'll just run a lot. And that really is not the approach. I think the gut training and nutrition aspect of ultra training is critical. So I think focusing on the GI training of this sport is important. So figuring out what foods work, what their sweat rate is, considering if they have the resources or inclination to do so, do sort of a metabolic testing and see what their sweat rate is to really optimize repletion. But that would be my recommendation.
All right. Well, thank you so much. It was a really, really outstanding talk. And thank you to Jeff for recommending you.
Thanks,
And
Jeff.
really, really happy to have you.